supplementary pelvic fixation, and lumbar or sacral fractures needed extension, or a tumor which needed extension to the fixation. So the entry point of iliac screws is identified by exposing the posterior superior iliac spine, and the entry point is placed slightly deep to the posterior superior iliac spine and along the medial aspect of the inner table of the ilium to reduce, especially in the thin patient, to reduce the prominence of the head of the screws. And again, the starting point of S2 alar iliac, it is just below the S1 foramen, again, and between S1 and S2, with 2 to 4 millimeter lateral and 4 to 8 millimeter distal to the S1 foramen. So with the navigation now, we really select the entry point depending on the navigation. We always look to the landmark anatomy, but we select it now with the navigation depending on, again, the landmark anatomy. So these are some cases, demonstrative cases with, this is a female of 68 with back pain and degenerative and neurogenic claudication with degenerative spine. And she has osteoporosis. She had this surgery again to support again, and here you have the post-op. Again, this is another female with 6-year history of low back pain and both lower limbs pain with numbness, left more than right, and she has neurogenic claudication with osteoporosis. And she has this, again, degenerative scoliosis. With stenosis. I'm sorry for this technology. Okay. So she underwent posterior spinal fixation from T11 to L5 with decompression of L2, 3, L3, 4, and L4, L5 with 2 levels stiff. And she was fine for some time. Then she came after discharge. She came back after a fall, and she was having sciatic pain in one side. This is after surgery, and she came back, and 1 month after a fall, and she started to have left leg pain. So we see that she fractured the pedicle at L5. And we had to go there to you can see here the pedicle, again the fracture in the vertebral body of L5. So the revision surgery was done with intraoperative. The left L5 broken pedicle was compressing the L5 nerve root. It was the symptomatic reason. And the excision of the pedicle was done with the compression of the root with removal of L5 screws and extension of fixation to the pelvis. And this is the situation after. And the patient is completely free. Symptom-free. And this is another case again with sacroiliac pain again. And we include the sacroiliac joint because she had confirmed sacroiliac pain resistant to the treatment. And here you can see the navigation, and you see how you can select your trajectory and the navigation. Okay, the sacroiliac, the iliac bone, and you can see where you are going, and you can select again the length of the screws. We use 8 millimeter screws, the diameter, and we use between 80 to 90 in general, the length. This is another case again with thoracic myelopathy, and we use it again for this long fusion. And this is another case with failure and the broken screws at L5, and we had to fuse to go ahead and to extend it. And this is again T11. Okay, we put the iliac screws, but doesn't mean it is not sure that you will be symptoms free, because the proximal, problem, it can happen, and the sagittal balance, again, if it is not respected, again, it can play against you and against your patient. So in this case, again, the patient has very good lower fixation, but the upper one, he developed, as you can see, this pedicle screw loosening. So we extended the fixation up and to... I'm sorry, I'm playing with this. Must include the sciatic notch and inner flanks of the iliac bone to accommodate long and large screws. Many patients complain of sacroiliac joint pain after sacroiliac area pain after the surgery, which improve progressively. We noticed that more than 50% of our patients after surgery, they complain of this pain, which improve progressively. But and here are some references. You are welcome again for our young colleagues who are interested in spine surgery to join the Arab Spine Course Diploma, which is organized in Dubai, and it is of 4 modules over 2 years. Each 6 months you have 1 module, and it is organized by the Arab Spine and the Arab Spine with the Spine Society of the Arabic World and the North American Spine Society, and we have this academic support from the RCSI, the Royal College of Surgeons of Ireland. And the last slide. Again, you are cordially invited to our 21st Dubai International Spine Conference in Dubai from 11 to 13 of April 2020 in Dubai. And in the name of the Arab Spine, again, you are invited to join the meeting in Amman, Jordan. Thank you very much.
Thank you very much, Dr. Mashhadi. We are running with the third speaker, Dr. Robertson, is going to talk about the spinal metastasis.
Is the pointer working? Thank you. I want to thank our moderator and our organizing committee for inviting me. It's a pleasure being here in Morocco again since our last meeting at the World Congress. As there's mentioned, I'm going to be speaking on treating metastatic spinal tumors with targeted radiofrequency ablation. Radiofrequency ablation has been around for a number of years, treating other forms of metastases, but really for the spine has not been used as frequently and as often as it should be. But I think this is going to be changing throughout the world. We're seeing an increase in metastatic spine disease, and the reason is because one is more people are living longer, so they're getting more cancer, and therefore they're also with better treatments now, they're also living longer with their cancer, and therefore they end up getting more metastatic disease. These are common types of tumors that we know have a predilection for the spine. Your typical myeloma, renal cell cancer, melanoma, thyroid, as well as breast and prostate are very common. In the United States, we're seeing an increasing rise, as I mentioned, with almost in the next 10 years, they're expecting a doubling almost of some of the metastases because success for treating primary is becoming more popular. Historically, as far as the role of the neurosurgeon and the spine surgeon, it's been, we were never consulted until it was too late. It was after the tumor had already invaded into the spinal canal, patients already had neurologic deficits, and so we were always called as a last resort to try to salvage. The radiation oncologist and took care and managed most of these patients. But I think this is changing. Our Academy of Oncology have developed new guidelines and new algorithms which have included the surgeon and the spinal surgeon, including minimally invasive ablation therapy right here. as part of the algorithm, as a treatment to treat early on. Once these metastases are identified, minimally invasive ablative therapy is considered part of a proper treatment in developing before they go to radiation and even sometimes before they start the chemotherapy. So in the past, we're familiar with radiation and single beam radiation were the primary sources treatments, and then surgical intervention was only if the patient had neurologic deficit. But this is where we're going to be seeing the neurosurgeon's role in the future in addressing these at a much sooner time. And one of the reasons why is it's because of this. We see in stereotactic radiotherapy alone, there's still a significant risk factor of 20% of these developing vertebral compression fractures, which can lead to further neurologic deficits. And we want to prevent that because we know when these patients develop these compression fractures, which have neurologic deterioration, you get a real significant increase in morbidity and mortality. This is as high as a patient when they develop a hip fracture. So you know how debilitating a hip fracture causes patients. These vertebral fractures cause the same sort of disability. So our goal is to treat these fractures early, reducing the tumor volume and treating the pain and getting these patients to mobilize. Now the cause for the pain is multifactorial. We have both the mechanical pain from the fractures with fracture-related instability, but then there's biological pain, stretching of the periosteum, surrounding tumor growth onto the nerve roots and tissues, as well as the endosteal nerve stimulation. As I mentioned before, we see increased mortality and relatively increase in morbidity and mortality associated with these diseases. With the spine fracture, like I mentioned, with the hip fracture, the patients have a 6.7 times risk of getting morbidity, increased mortality. Look at what we see with spine fractures, so it's even higher than that. So that's why it's important for every spine surgeon to start treating these and treating them early. That's our message that we're going to hear today. And like I said, in the past, it was always the first line was always sit and watch, and then they would only consider open surgery if there was a neurologic deficit. Well, then we started treating with vertebroplasty or kyphoplasty alone, and we found that this helped with the pain, but it wasn't doing anything for the tumors. Now we're talking about both. We're adding radiofrequency ablation to reduce the tumor volume, and I'll show you in some of the other studies why the benefits of this, in addition to augmenting to stabilize that fracture and preventing that 20 or 30% from going on to develop a really debilitating fracture. And this is it. This is the real take-home message of this. Why am I talking about all of this? And just for this reason, you don't want this to happen from going from January to this. This changes a person's life dramatically. You know, here you can treat this with a 20-minute procedure. The patient goes home. Now they're in the hospital. They'll probably end up going to a nursing home. They're going to have permanent neurologic deficit because we waited too long or we didn't treat it appropriately. So the goal is, again, debulking and decompressing, stabilizing the vertebrae are our major goals in this sort of treatment. This is a procedure that any spine surgeon can do. I mean, it's a simple percutaneous procedure. It's a short procedure time and little postoperative pain. If you're putting in pedicle screws or if you're already doing vertebral augmentations, this is just one added step into it. And I just think it's something that you should really take advantage of and add it to your practice. You just need a basic C-arm to do these procedures. This is just, and I'm not promoting any one company or anything, but this is just one company that's out there. All of these systems involve some sort of radiofrequency generator. They'll have various types of probes. This is a nice one because it actually steers. You can steer this probe in and twist it in multiple directions and ablate in multiple parts of the vertebral body. So it's just a nice format. The technology behind this, in all of these, you have a thermocouple probe that creates a radiofrequency heat zone, and just by knowing the pattern that this controlled thermal distribution is going to be, you can steer this probe into different parts of the vertebral body, even within the pedicle, where we commonly see the first signs of metastases. You can steer this into the pedicle, ablate the tumor in the pedicle, and then fill that with some backfilling with cement to stabilize that pedicle even. So just understanding the principles of the ablation zone, you're able to then treat these. And these are just, I'm going to run through some samples. This is a sample of metastases. percutaneous cannulas go down. Through that cannula, you can create a cavity within the tumor and the vertebral body, and then right through there, the ablation goes through, and then you can backfill it with cement to fill for the fracture. So those are the basic principles behind this procedure. Can we move to the next slide, please? Doesn't seem to be working. Oh, there we go. These are a couple of clinical studies. I won't spend a lot of time on them. I was involved in a couple of these, but these were over several institutes collecting 101 spinal lesions in this. You can see the cancer types typically involved. You know, the main outcome was looking at the visual analog score. How did these patients do? How was their pain controlled? We need further studies to look at also, and some of this is coming out on how well is the tumor controlled. So we're looking at pain, which is the main thing, but in addition, then how well are these patients responding to their further treatment afterwards. And this is another study, and what we do see here is there's a significant reduction pre-procedural versus post-procedural pain. Again, this just reiterates the same thing. These patients get immediate significant pain relief, which is a nice thing to see from this procedure. These patients oftentimes come in and they're bedbound, and they walk out the next day ambulating. So it's a very good procedure. Pain decreased by typically 77%. Again, this shows where in the past the patients were just undergoing cement augmentation. But what's happening then is that they will develop tumors later on. And so that's why the new stage is to add in, before doing the augmentation, adding in the radiofrequency ablation, and we're seeing much better control of these tumors. Even radio-resistant tumors. This is a patient here who had simply at L2 and L3 ablated and cement augmentation. Two others just received radiotherapy, single beam proton, and we see all four of these received it, but these two, because they also had the augmentation done or the radiofrequency ablation, their tumors well controlled at 6 months, where these still show tumor growth. So what we're finding is by reducing the tumor volume and debulking and even devascularizing it, it's helping control even radio-resistant tumors, and that's some promising information that we're seeing. Again, this summarizes that last slide with these two received radiation therapy alone. These two got radiotherapy with the RF ablation, and we see that they're much better controlled at 6 months. This is recently published. This is an example of a 36-year-old with the T10 myeloma, and you can see what we're able to do here with going and cementing and even getting all the way through the pedicle and being able to ablate into that area. This is just a patient I just saw a few weeks ago in the clinic. Had tumors here. We did ablation, augmentation. She underwent her radiation, and now look, we see that epidural component is gone. So these are, again, just some additional summaries. This kind of shows an example of how this probe can be steered and going all the way across midline and in various directions. And part of it is even an incomplete ablation is better than no ablation at all. Examples, and you can do multiple levels. This is a patient that had 10 different levels done, and you can do it all in one setting, very quick and easy. So to summarize, targeted radiofrequency ablation and bone cement augmentation provides instant stability, significant pain relief, short surgical time, very low risk to the patient. These procedures may be repeated for other lesions and helps lower morbidity and improves the quality of life. In addition, now the newer studies have showed that they're getting even the radiation oncologists are able to reduce the amount of radiation they use, which helps prevent further nerve damage, and it doesn't interfere with their chemo or further radiation treatment. Thank you very much.
Thank you very much, Dr. Robertson. The next speaker is Dr. Al-Mashani. Is going to talk about the supraorbital keyhole craniotomy.
I think that is making the quality of the picture is not that good, so they are changing it. Good afternoon. Thank you very much. I appreciate Dr. Abdul Samad and his colleagues for this nice conference. Thank you very much. There is no disclosure. Just the same slides which is earlier I do. This is the, the topic is keyhole craniotomy for excision of tumors and clipping of aneurysm in pediatric. There is, we have to think about what is the best for the patient rather than what is, the best for me as a surgeon. So this slide, which is I presented in the previous presentation, so we have to think what can be done. So if we are seeing this is the reality of that picture, so that is a reflection of it in the water. So this is always when I'm presenting this talk, this is the slide which is I like it. When I'm traveling, you can see these bars in the airport. When you have a bag, you are pulling the bag, you have to turn the bag this way, because that perception in my mind, that is, it will not enter in this space. So the space is the space is smaller than the bag itself. Then one day, this is what is usually our perception. Always we see something, we have in our mind some perception which may not work. So that is not the right, so we have to think in the right way. Why I have to do it that way rather than to do it in the normal way? So that's why, so I pass it through, so it's passed. So that is what is make me to change my way from conventional surgery for craniotomy to make just a small craniotomy or keyhole surgery for pediatric. So this is the concept. So this is the first case, which is almost I start with. When the registrar or the fellow, he went to the surgery, he thought I will do terunal. So when he came here, he was in another unit, but he transferred from the other unit to my unit. So he started to shave the hair for terunal surgery. So then when I came, we hold it. So I do just. This is. So the small incision here in the eyebrow, then that incision is so it's like that. Then this is the craniotomy which is I need. When we do a terunal incision, just we remove the big flap, dissect down, then we did the craniotomy, and from that where the microscope we use. So you are exposing the brain to the environment, which is also can be exposed, can be dry during your procedure, can be also seizure causes. But we need a small bone for this. So then from your microscope, you can see that big area wherever you want to go. You want to the other side, even if you're right, you can see up to the left and so on. So that is your, approach to the lesion itself. So you can see where down after the incision. Oh, I think there is. Okay, this is the bone which you remove it, and you can take your care of your surgery. So this is reported it, and it's in the American Journal. This is a case which is an 8-year-old boy with opticochiasmatic glioma. We operated in him in 2012, and the last 16, this is his picture. He sent, I follow him, even the family, they have in contact 3 months ago. He looks younger. I hope I have his picture. And you can see this is the tumor which he has. He already has lost vision in one eye, and the other one is just, he can see, he can read. He's in the school, he can read, but it's not that clear as normal. So I was hesitating, shall we do a terminal or shall we do this one, supraorbital approach? And we did a supraorbital approach, and you can see the incision here, which is we remove with that one the tumor. And that is we control the tumor now. He is 8 years from that to now it's 11 years. When we operate on him on 12, and his age is now 19 years, and we operate on him on 2012. This is the previous case, which is she's 8 years, the same, with hypothalamic chiasmatic tumor. That is the incision. This is another child, which is she bleed in the hypothalamus, and that is the one she came comatose. We operate on her, and that the only which is in the morning, that is in craniopharyngioma. What is the problem? Is the hormonal effect. This is after a bleed, even with the supplement of hormonal, she still became obese. And this is, she follow up in the clinic, and this is with her father. And that is, we removed total the tumor with the bleed, with the blood itself in the same approach. This is a follow-up MRI, you can see here. And this is the craniotomy site, which we can see. So the other thing, which is also in this 2 years old, she has a loss of vision right eye and light perception on the left eye. That is, she is only 2 years. And with that, you can see the tumor here, the sagittal as well as coronal here. The only thing which is, this is one always, this is a miracle. In a way, that is the one which is, I cannot believe unless you see. This is always, I'm telling that is a miracle. In a way that, if you see here in the CT scan, next day we did a CT scan, because after we did a craniotomy, I was thinking that is it craniopharyngioma or is it glioma? So I told the family that is, if it's craniopharyngioma, it's easy to remove, but if it's glioma itself, it will be difficult. Maybe I have to quit. I just take a biopsy, and that is the one. Then when we are in we found that it's glioma, so I went to the family and explained to them that this is a glioma rather than a craniopharyngioma. So with that, she said, the mother, please operate, remove the tumor. You are not the one who is cured here. The God, Allah, who is the one who cured here. So go ahead and remove the tumor. So we removed the tumor. The next day, she is still seeing. So the registrar, he asked, sir, we have already the child, she's still seeing. With that is the one, sure she is seeing. So we found this a strip of blood, which is going on the optic nerve, which we removed. And with that eye, she's still removing. She's still seeing. So tumor can be as this, which is huge. Tumor like this, which is, this is post-op hair MRI, and we can remove it with the same, approach. The other thing, this is the same patient. You can see, but this, unfortunately, that is a video which you can see after. You can see the incision here. The other thing, which is a 6-month-old with history of failure to thrive, cachexia, decreased vision, unable to sit, and her only weight is 3 kilos. And that is the one. With the terminal, she will bleed before you reach. You have to transfuse her. With that, you can operate on her with a small incision like this, and the patient is total removing of the tumor. And that is her pre and post MRI. We can clip aneurysm With that, this is a 13 years old, and this is the ACAM aneurysm, and that is the clip here. You can see the clip. With that, you can take aneurysm in pediatric, also tumors. So with this, we conclude that is supraorbital approach is a nice, safe approach for pediatric, and the advantage of it is it's a quick surgery, less loss of blood. In the same time, the cosmetic is not that problem, and it's fast recovery. Thank you very much.
Thank you, Professor Mashani.
This is Oman, by the way. That is the picture of.
Thank you. And welcome again to the WFNS Yoga Neurosurgeon Forum session. May I call Professor Talat Case, who will give us a talk about fluorescein-guided neurosurgery. So, Professor Kiris is the president of Turkish Neurosurgical Society and board member of the Mediterranean Association of Neurosurgical Societies, and very interested and applicated in the yoga neurosurgeon activities. Thank you.
Mr. Chairman, dear colleagues, it is in the coffee break. It was good. No, now it's working. Okay. Again, good afternoon. So neurosurgery, modern neurosurgery started at the beginning of 20th century with headlamps and monopolar Cotard, and then the paradigm shift 50 years later when microscope and bipolar is applied to neurosurgery, and then come to the new technologies and new devices. And today I will talk about fluorescein-guided neurosurgery. What is it? It is a kind of neurochemical navigation. We can talk about intraoperative imaging of vessels and blood flow, intraoperative imaging of tumor tissue, or photodynamic direction of tumor tissue. These are the main drugs that we use, and anecdotal case reports here with other drugs. Indocyanine green we use mainly for neurovascular, and 5-ALA mainly for the tumor, but we can use sodium fluorescein for both pathologies, and I will focus on sodium fluorescein because the time limit. It is not a new idea. Back in 1948, Moore suggested to use it, and then efforts made for development of a dedicated microscope for fluorescein, and recently we have dedicated filters and microscope for this. It's a synthetic organic compound, and our ophthalmic surgeon colleagues use it for almost 5 decades. It accumulates in a disrupted blood-brain barrier due to pathologically increased vascular ability. It is just like gadolinium. Whenever you see contrast enhancement in the MRI, what is white, you can see yellow in your surgery. It is the same. First, surgeons used high-dose sodium fluorescein with white light, but anaphylactic and allergic reactions has been reported. And then, after the dedicated filter with low doses, paper came out with this technique very recently. We published our first experience in 2016 with gliomas and metastasis. Just an example, an insular high-grade glioma here. Insula is dissected, and when we turn it to the filter, you can very nicely see the yellow tumor, and then you take it out. You can turn to white light and to yellow light, and then at the end, if there is no more yellow tissue, it means that it is total removal. Here, it's postoperative and postoperative. This is another case. Before we considered this kind of tumors inoperable, but now we can operate just like other glial tumors. I skipped the video here, but you can see the pre- and postoperative MRI scans. Then in 2017, we published our experience with meningiomas. In fact, this is the first paper in the literature about sodium fluorescein and meningiomas. And we describe the techniques we used. We can use it as angiogram during dissection, or we can detect tumors, for example, if there is bone invasion. Here you can see the angiogram after skull-base meningioma was removed. This is a medial sphenoid wing meningioma. It's almost the big part is removed. Now there is a tumor on the carotid bifurcation. Now we can make sodium fluorescein angiography and to visualize the tiny vessels, the lenticulostriate arteries, which are stick to the tumor capsule, and dissect these vessels under direct visualization. I found it very useful in this type of surgery. I don't want to show you the whole video, but you can see very nicely these tiny vessels, and you can make the surgery. And this is pre and post-op. Another case, tuberculum cellular meningioma. Here I used also endoscope. We can use different technologies together. Here, with endoscope, I looked the relationship of the tumor, and here is internal carotid artery, optic nerve, and the tumor is very sticky here. And then we start to dissection. This remember tuberculum cellular meningioma. So here we have superior hypophyseal artery. We can keep intact superior hypophyseal artery with again sodium fluorescein angiography, and under yellow filter we can dissect this tiny vessel easily. Also in skull-based tumors, I found it useful. We didn't publish this, but I showed this yesterday during removal of this chondrosarcoma. I do time to time angiography and see the perforators on the originating from the ICA, and this is postoperative. Then very recently we published our experience with pediatric cases, 23 pediatric cases. This is also the first paper about this topic, and we showed that it is possible to use it also in children, sodium fluorescein angiography. One example is this choroid plexus papilloma. We make a sulcal dissection, and you can see very bright when we turn the yellow filter, very bright tumor staining, and you can work under the filter. It is just like to working in the white light, almost the same, and you can remove it, and the beauty of the sulcal dissection is it is like the brain looks like untouched after the surgery. And this is pre- and post-operatives. We collaborate with two groups in Europe, one group in Italy and one group in Germany, and we make also publications together. This is a publication we did with Milan and Regensburg groups, intramedullary tumors and recurrent glioblastoma, again in sodium fluorescein. And also, it's possible to use this in neurovascular cases. You can see very beautifully the angiogram in the cases. I showed this yesterday during my talk about aneurysms. The lenticular striate arteries is depicted very nicely with sodium fluorescein angiography. This is a carcinoma. During removal of these lesions, you can make angiogram and to see the en passage vessels and keep them intact. And after removal with angiogram, you can see the surrounding vessels, they are all intact. So if we compare indocyanine green and sodium fluorescein angiogram, I found ICG more useful in AVM surgery to show the big conducting vessels, and sodium fluorescein more useful in aneurysm surgery, especially for these lenticular striate arteries. It's also possible to use it in CSF fistula. I have limited experience, only 2 cases. We use it in 2 protocols, with tumor protocol and vascular protocol. In tumor protocol, we inject 2 milliliter with the anesthesia induction, and in vascular protocol, 0.5 to 1 milliliter, and we can inject 5 to 10 times. So it's possible to make 5 to 10 angiograms during surgery with vascular protocol. There are also pitfalls, naturally. If we make a trauma during surgery, after half an hour to 1 hour, you can see the trauma site as yellow, and dura and ependym show staining with sodium fluorescein. You must be aware of that. And also, if you may operate a recurrent glioblastoma, you have to know that also radiation necrosis will enhance with sodium fluorescein. So as conclusion, the dedicated microscope with yellow filter, now most of the important microscope companies have this filter in their microscopes. 10% of sodium fluorescein, 2 to 5 milligram per kilogram body weight. Important is this is off-label use. So it is not allowed for neurosurgery, but since the ophthalmologist use it in the last 50 years, we use from the same way with the same doses, so it is not a problem. Contrast enhancement in MRI equals sodium fluorescein during surgery. In some patients, we see a transient yellowish turnover, and I found it very beneficial in neuro-oncologic and neurovascular surgery. And we founded a European network of fluorescent-guided neurosurgery in last year, actually, and now we are preparing an international conference on that issue. Thank you very much.
Thank you. Thank you, Professor Case. May I call Professor Abdelhafiz Shihabdin to give his talk titled Endoscopic Sterectomy for Stenosis. So, Professor Shihabdin is past president of the Middle East Spine Society, head of Department of Neurosurgery of Sahil Hospital, and he gives us a webinar a few months ago during the WFNS Neurosurgeon Forum webinars. We have webinars every month for our session in WFNS, and let's move to this talk.
Mr. Chairman, dear colleagues, I think that we are in the afternoon now and everybody is lazy, but okay, let us start. Our talk now is about endoscopic sterectomy for primary craniosynostosis in infants. And actually humans are unique among mammals because humans are bipedal and with a narrow pelvic outlet. And that's why, and of course, we all have a big brain compared with animals and cows. So, but we have to go through birth. Our brain should be small. So, although a cow can walk immediately after its birth, the humans, they take maybe 15 months to do that. And if we look back to the embryology and the development, the human cranium develops from mesoderm and the neural crest, and this begins at the age of 5 weeks gestation. And we have neurocranium, and that gives rise to cartilaginous neurocranium, and later the skull base. And viscerocranium will give rise to the membranous neurocranium, which is the bones, or flat bones of the skull. The neurocranium or the flat bones achieves it's about 30% of its size by birth, and 88% by 1 year, 85 by 10 years. And the description of cranial deformity is recognized back by Galen and Hippocrates, but they are describing it in terms of prominences like the anterior prominence and posterior prominence. But von Schumering in 1790s go behind that, and he was speaking about the abnormal cranial suture growth. And if we like to Rodolph Virchow, and he is starting to speak about cranial growth occurs as a direct result of the growing brain. So he describes the relation between the brain and the skull. And once a suture becomes fused, growth perpendicular to that suture becomes restricted. And the frequency, as has been mentioned in the morning, is rare. It may be 0.4 to 1 for each 1,000 persons. And each suture gives us its characteristic deformity, like sagittal suture or craniosynostosis will give to scaphocephaly. And in addition to that, there is a 7% chance of increased intracranial pressure with one suture synostosis. And if more than one suture is involved, this means that the risk is increasing. And the multiple suture affection occurs in about 14% of the cases, and 15% is associated with craniofacial syndromes. Why the sutures prematurely fused? There are genetic mutations in addition to teratogenesis, environmental factors, and local intrauterine factors related to an abnormal constraint of the fetus. And the skull, brain, and the dura mater develops in an intimate physical and biochemical contact with one another. And the dura plays a very important regulatory key role for that. The clinical evaluation of craniosynostosis should be started at birth early, and it should be diagnosed as there is a cranial deformity. And the diagnosis relies on the physical examination and radiographic studies. And by that way, you can avoid permanent deformity and the progression of this abnormality of the calvarial shape. We have to differentiate lambdoid synostosis from deformational plagiocephaly, because if for lambdoid synostosis, you can find that the forehead of the child and his ears are pushed backwards, whereas in positional deformation, both the forehead and the ear, ipsilateral ear, are displaced forwards. And this is important to recognize that, of course, in addition to the radiological evaluation that includes the plain X-rays, skulls, and the CT scan with 3D reconstruction, and also ultrasonography may be used up to 13 months. The treatment is either non-surgical with head molding therapy or through surgery. And the surgical goal is to increase the intracranial volume and prevent complications and especially neurological ones. And the manifestation of increased intracranial pressure with impaired neurological and cognitive growth, blindness, and hydrocephalus, and the marked deformity of the skull. So surgery is best performed early in infancy, as most brain growth occurs in the first year of life. The approaches has been mentioned again today, including strip craniotomy for the fused suture, in addition to bi-procedures for the sagittal suture, or strip craniectomy for the coronal one, and maybe you need also fronto-orbital advancement if the child is above 6 months or 1 year with gross deformity. And if there is hypertolerism, then orbital, and the orbits are too far from each other, then orbital bone cuts are made to free the orbits from the skull and the face, and followed by reconstruction and mini plates. For myotopic synostosis, maybe you need strip craniotomy and the fronto-orbital advancement. But for deformational biaglocephaly, again, we have to differentiate it from craniosynostosis of the lambdoid sutures. But repositioning and the helmet therapy may be enough, and the only surgery for advanced cases. In the early 1990s, Jimenez and Brown recognized the limitation of the approaches and the extensive operations in young children, blood loss and blood transfusion, and severe scalp mobilization. And they proposed a technique of simple suturectomy via an endoscopic approach. And the success of the procedure, in their opinion, that it should be done early in life. Second, the rapidly growing brain will cause expansion of the skull into a normal shape. And they advised also the use of post-operative helmet to guide the direction of the growth of the skull. So my patients includes only infants and presents with primary craniosynostosis. It's the 50 cases treated with endoscopic assisted suturectomy. And after clinical and radiological evaluations, it's important to define the cranial index, which is the cranial width and divided by the cranial depth. And if we look to the cranial index, in addition to, of course, to head circumference, for normal head, the cranial index for mesocephalic hand is ranging from 76% to 79%. For dolichocephalic head, it is less than 75%. For brachycephalic head, it is more than 80%. That is the position, and the position should be fashioned according to, this is for sagittal synostosis repair. And you have to give some attention to adequate ventilation and the circulatory dynamics, in addition to the body temperature, hypothermia, and the amount of blood loss. For sagittal synostosis repair, we are using just two incisions, one behind the anterior fontanelle, about 2 centimeters, and one in front of the posterior fontanelle. And here is the amount of strip craniectomy that will be done. And adjacent sutures at the beginning, first 2 or 3 centimeters, will be also removed. And this is the cuts that will be done. Skin incisions, as I mentioned, is about 2 centimeters. And it should be, here for lambdoid sutures, it should be in the middle and perpendicular to the suture line. And using 4 millimeters zero length endoscope, we start by subgallial dissection along the whole length of the suture, with the proximal portion also of the adjacent sutures. Burr hole, single burr hole, is to be done just beside the suture line on one side only, and the endoscope is used for blunt dissection of the endosteum from the dura along the suture to be removed. And for suturectomy, you are using nibblers, you can use scissors, you can use drills. Especially for coronal sutures, you have to extend your craniectomy to the skull base to correct the deformity. Bleeding is used to be controlled with monopolar coagulation of the craniectomy edge. And again, also, as I mentioned, you have to extend the full coronal suture to the skull base. That's the results. I will go directly for the cases. That's, if we look here, the head circumference of our patients, the mean is improved from 39 centimeters to 43 centimeters by the age by 6 months after surgery. Cranial index is improved from 86% to 83%. And if we look for that case, that's 4 months baby showing brachycephalic head, and you can see also that there is fused both coronal sutures. And here is intraoperative photo, and here is the post-operative one, and you can see the strip craniectomy here. And here is the child that's pre-operative, that's post-operative 6 months, and that is at the age of 4 years. Another case with both coronal sutures and partially sinustosed sagittal suture also. And again, that is the craniectomy that has been done, and we can see here that's pre-operative and post-operative one. For metopic synostosis, like this case, and the trigonocephaly, that's here post-operative, that's 4 months post-operatively. Another patient with anterior pelagiocephaly, that's pre-operative, that's post-operative, and you can see the child here after 3.5 years, that's pre-operative, that's 6 months, that is 4 years. Helmet therapy, we don't use it for our cases, but we are relying on the growth of the brain for correction of the deformity. But there is another techniques like this spring-mediated cranioplasty that you can put it to enlarge your defect and to avoid refusion. And also, this distractor has been advised also to perform the same. In conclusion, evaluation of suspected infants should be early and include complete clinical and radiological evaluation by X-rays, CT scan, and others. And the many surgical options are available, but endoscopic assisted suturectomy is a good approach and with a very narrow range of complications. Thank you.
Thank you. Let's move to the presentation or talk of Professor Angel Orca Jadas. I hope that I pronounce this correctly. Not yet. Not correct, I think. So the talk is titled Intracranial Pressure Monitoring Clinical Application.
Excuse me, there is no remote control.
For the next session, please prepare your talks to not lose so much time. Thank you. You can go to the desk there and leave your talks. Thank you.
First of all, I would like to express my gratitude for the organizing committee for inviting me to this fantastic meeting. So after this presentation about big surgery, my topic is completely different. It's about ICP monitoring and their clinical application. We all know that isolated measurements of ICP are useful for acute intracranial hypertension, but continuous monitoring is necessary because ICP is not constant and isolated measurements may be normal. Not only the figures of ICP are important, but also the morphology of the recording. The first who take a measurement of ICP was Quink in 1897, and the first paper published about it was by Guillem and Jenny in 1951. But really, the modern age of intra-ICP recording started with Niels Lambert in 1960 when he published his doctoral thesis about ICP monitoring. ICP monitoring is based in the recognition of the waves described by Lambert in 1960, the E waves or plateau waves and the B waves. And after Lambert, another subtypes of waves has been described. For example, A pre-plateau waves that are shorter and smaller than plateau waves. And also B waves has been subclassified into low amplitude weak waves and high amplitude big waves, depending if the amplitude of the wave is less or higher than 10 millimeters. We use for monitorization software for registration and graphic representation of ICP called NeuroPicture that capture data from an intraparenchymal sensor and a monitor provided by Integra. The ICP procedure is done under local anesthesia with prophylactic antibiotics. We connect the monitor to a PC, and we record the ICP at work for at least 72 hours, and we can remove the sensor at work. From our point of view, there are a lot of situations where ICP monitoring is very useful. We are going to start talking about the indication in adult chronic hydrocephalus. We all know that the clinical picture of NPH is not diagnostic. Triad is often incomplete, and sometimes there is coexisting illnesses that can obscure the clinical picture. And from the radiological point of view, there is no radiological features that can diagnose this entity. And about the diagnostic test used in NPH for diagnosis, both TAP test and hydrodynamic test, the problem is false negatives. So in this situation, ICP monitoring becomes the gold standard for selection the patient for shunt. We published our experience in NPH patient some years ago. It was a series of 38 patients. In this kind of patient, in NPH, the most common findings are B waves, low amplitude and high amplitude B waves, and we selected for shunt those patients that showed low amplitude B waves in more than 20% of the night recording, on those patients that show high amplitude B waves in any ICP recording. So with this criteria, the percentage of improvement of this series was 75%. What is more interesting was that the patient who showed high amplitude B waves, the percentage of improvement was around 85%. So high amplitude B waves is a good prognosis for shunt response. Another group of patients where ICP monitoring is useful is the patient with suspicion of shunt malfunction. Acute malfunction is easily diagnosed, but chronic dysfunction is not so easy. Sometimes the patient complains of unspecific symptoms like headache, visual disturbances, gait problems, and radiology sometimes is difficult to interpret because they are patients with shunt sometimes since birth, so the ventricles can be dysmorphic or can be rigid, so it's difficult to interpret. So in these cases, ICP monitoring is very useful. We're going to show some examples. This is a male, 13 years old, shunt at birth with episode of recurrent headache and without papilledema. We performed an ICP monitoring, and the ICP monitoring was striking, really, with pre-plateau B waves and high amplitude B waves, and ICP reaching 70, 80, and 90. Another advantage of ICP monitoring is that you can prolong monitoring after the treatment, so you can test if the shunt revision, if the surgery is working. This is a ICP recording after the treatment. This is another case, similar from the clinical point of view, recurrent headache, no papilledema, 34 years old, with this radiology, really it's not striking. But the ICP recording, again, is very pathological, with pre-plateau big waves and high amplitude big waves and ICP reaching 70, 80 millimeters. And this last case is a 20 years old man with a myelomeningocele, operated at birth, with a shunt also since birth, that start complaining of weakness in upper limbs. In MRI, we show this ventriculomegaly very similar to previous MRIs, and in the cervical MRI was evident and chiari malformation and a huge syringomyelia. Instead of doing a posterior fossa decompression, we wonder if the shunt was working or not. So in this patient, we perform an ICP recording, and again we will see high amplitude big waves with ICP about 30, 40. So this patient was treated by shunt revision, and this is the result after the shunt revision. Ventriculomegaly is another good indication for ICP monitoring. We all know that ventriculomegaly is not synonymous of intracranial hypertension. Sometimes ventriculomegaly is an incidental finding, or sometimes it's related to specific symptoms. And we all know that to shun a ventriculomegaly without a correct diagnosis could be assessed. So in these cases, ICP monitoring could be very, very useful. We are going to present 4 cases very similar from the radiological point of view, where you can see how different are the ICP recording in this patient. The first 2 cases with high amplitude big waves, the third case with low amplitude big waves in most of the ICP recording. The last case was considered normal. ICP monitoring not only help us to select the patient for treatment, but also to choose the correct shunt and the correct opening pressure. Idiopathic intracranial hypertension is another group of patients where ICP monitoring is useful. We all know the diagnostic criteria for this entity, but there is some problem. What are these problems? Incomplete forms. There are forms without papilledema, and there are also patients with papilledema, but with lumbar opening pressure less than 25 centimeters of water. Another problem is the patient with optic atrophy from previous episodes of intracranial hypertension. In this case, funduscopy is useless. And the last problem is to test if a lumboperitoneal shunt is working or not. In these cases, ICP monitoring is very useful. These 3 cases, very similar from the clinical point of view, headache and subjective visual loss. And the ICP recording was completely different. The 2 first, very pathological with big waves, high amplitude big waves and pre-plateau waves. The last one was considered normal. Another case, a case of idiopathic intracranial hypertension without papilledema. And again, the ICP recording gives us the diagnosis. And also to check if the shunt is working or not. The first ICP recording is before the shunt, and the second one was done a month after the shunt, because the patient still was complaining of headache. And the last group of patients where ICP monitoring is very useful are arachnoid cysts. Sometimes arachnoid cysts are incidental finding, or sometimes a patient complains of numbness or headache or whatever, and sometimes radiology shows a mass effect. So in these cases, ICP monitoring is useful. We are going to present two cases. The first case is a small posterior fossa arachnoid size, a woman complaining of severe headache for some months before coming to us, and we performed the ICP recording. The ICP recording showed these high amplitude big waves. We treat this patient with a cystoperitoneal shunt with very good response. And the second case is a huge hemispheric arachnoid cyst complaining of headache and numbness, and in this case the ICP recording was completely normal, so we did nothing. We have monitored that more than 300 cases, most of them adult chronic hydrocephalus and shall malfunction. We have had only 2 complications, one intracerebral hemorrhage and one CSF fistula. And to conclude, I would like to say that ICP monitoring is a safe and an easy procedure that provides valuable information about CSF dynamics and is very helpful in taking decisions about the best treatment for a patient and avoid unnecessary surgeries. I would like to finish leaving an open question to the world, and this is if an internist don't hesitate to measure blood pressure to treat hypertension, why a neurosurgeon is so reluctant to do the same about intracranial pressure before treating CSF disturbances. Thank you very much for your attention.
Necessary to be treated, and this is, I highlight, is excellent, I think. But it's the way you will do the monitoring. You will make as a local and insert and see intracranial, or you do a lumbar and you will see the. So in that, this is a one, and in that you just a one, and then you read it, or you wait and you see what is, because sometimes we know that is like a normal pressure hydrocephalus. That is a one is, you know, just a period, it will be a normal, then that.
Okay, thank you. About the first question, yes, we use an intraparenchymal sensor, Camino sensor, because this software we designed by us and is designed for this sensor. We do it at OR, under local anesthesia, yes. Yes. And we prolong the ICP recording for at least 72 hours because of this, because you have to see these big waves, and big waves are related to REM period during night. So it's better to prolong the ICP recording until you see the pathological big waves. So before removing the ICP sensor, we look at the recording, and if it's necessary, we prolong ICP recording for 3, 4, 5, 6, or whatever you need.
Based on your ICP monitoring, you didn't say how often the patient improved after the surgery.
Yes, I haven't said because I had only 10 minutes for a long series of patients. In hydrocephalus, in chronic hydrocephalus, 75%, I've said. In the other, around 80, 90%, depending on, for example, in intracranial, in idiopathic hypertension, all the patients monitored improve after the treatment, because the best of this ICP monitoring is you can select the patient for surgery, so it's difficult to select the wrong patient. You know, ventriculomegaly, you are sure that the intracranial pressure is not correct, so you are going to select the right patient. So in these cases, the percentage of success is very high. So I think it's the best quality of this monitoring.
Thank you.
I would like to
think
ask
you have
one
question. Last question, yes. No more question?
We have time, only one question, because we are limited our time. That is why. Last question, please.
Excuse me. Thank you for the good speech. Just a question. You use for pressure intracranial the detector Codman or echodoppler intracranial, or you measure diameter of the nerve optic. You can use these three techniques for measure the pressure intracranial. What's the good technique?
My talk is about indication of ICP monitoring in chronic patients. You know, for severe head trauma, you can use especially Codman sensor or Camino sensor or whatever. We use this Camino sensor because we designed the software for this Camino sensor specifically. And you know, the gold standard for ICP monitoring is, you know, intraventricular sensor. Intraparenchymal sensor is close to interventricular sensor, and the other depth Doppler and optic nerve and is not so accurate to measure ICP. So I don't know if I have answered your question.
Thank you very much. We are closing the session.
Would the speakers please make sure they have their talks turned in unless they're using their own laptop? We're already 55 minutes behind, so we'd like to remind everyone to keep on pace and respect the time so we can finish. Is the first speaker, you're ready?
Yes.
Okay. Well, we'll go ahead and begin just to respect everybody else's time. Our first speaker is Dr. Habibu from Niger. He'll be speaking on management of encephaloceles in National Hospital of Zinder in Niger. Oh.
Did not come, so
Okay.
I'm Dr. Udwiri. This is mine.
Odri. Okay. Sorry about that. So we'll have the first speaker who did not show. So Dr. Odri will be speaking from Morocco on skull base reconstruction after endoscopic transsphenoidal surgery.
Okay, hello everyone. Thank you, Mr. Chairman. So my talk will be on skull base reconstruction after endoscopic transsphenoidal surgery. So the endoscopic techniques came as an evolution of the transsphenoidal surgery that dates back already to the ancient Egyptian times. And to date, this endoscopic transsphenoidal approach is being considered as a standard of care for all pituitary tumors and being increasingly used for related paracellular and skull base pathology. The advantages offered by the endoscope and the adaptation of instruments and techniques is allowing for more aggressive, or let's say more extended approaches. These endoscopic techniques, so since the first attempts to tumor resection, pituitary tumor resection through the transsphenoidal approach, it became clear that one of the main concerns will be about cellular reconstruction and skull base reconstruction. So after a tumor surgery and following a successful resection, one should be able to define an appropriate exit strategy to avoid one of the most frequent complications, that is CSF leakage, and with all the related morbidity, there is meningitis, pneumocephalus, and etc. There are multiple closure techniques, but all share the same principles. There is ensuring an inlay. So it's not working. Ensuring an inlay, an onlay, and then an overlay. So the inlay is put into the tumor cavity and aims to reduce or stop the CSF flow. It can be fat, muscle, fascia, collagen or gelatin sponge, or even dural substitute if you had a chance to have. The only, which means the buttress is put into the intracellular extradural space and should be solid enough to hold the construct in place and block and resist the CSF and brain pulsations. It can be autologous, harvested from the septal bone or septal cartilage, or synthetic, like titanium meshes, or even sometimes sutures. Actually, many papers describe the recently suturing techniques as an adjunct to the buttress. The overlay will cover all the construct from above. It can be fat, mucosal graft, or flap, mainly the nasoseptal flap that's the one that is most used, that has transformed the prognosis and outcome of patients since its first introduction by Haddad in 2006. So depending on the CSF leakage grade, different combinations of these three steps will be used. The most used grading system for assessing intraoperative CSF is the one published by Esposito in 2007. Where we can see 4 grades. This system was reassessed in 2019 lately in this article. So the grade 0 is a grade where there is no CSF leak, and even after Valsalva maneuver. The grade 1 is a small weeping leak confirmed by Valsalva maneuver without obvious or only a small diaphragmatic defect. The grade 2, a moderate cerebrospinal fluid leak with obvious diaphragmatic defect, and the grade 3, which is a large cerebrospinal fluid leak, typically created as part of an extended approach. Here's some insight from our case series. So we started on endoscopic transfemoral approach 2 years ago after a long experience on microsurgical transfemoral approach. To date, we have 54 patients. Most of them are pituitary adenomas, and 73 of which are macroadenomas with large supracellular extension, 5 cases of craniopharyngiomas, 1 clival chordoma, and 1 inverted papilloma. In this series, we've had 30% of perioperative CSF leaked, 8 grade 1, 6 grade 2, and 2 grade 3. And the postoperative results, no CSF leak after the reconstruction with no lumbar drainage needed postoperatively. So our graded repair algorithm is as follows. For grade 0 cases, we only use hemostatic agents, collagen or gelatin sponge whenever available. Fat, only if a large cavity is encountered, like in large tumors, with the bulging of the diaphragm, and then we re-expand the dura and the sphenoidal mucosa. Reconstruction of the cellular floor with bone is not really mandatory for these cases. For the grade 1 cases, we put inlay fat, dural suturing, as long as dural edges are intact, the bone buttress, mandatory, and then a sealant like the bioglue. For the grade 2 cases, inlay fat, dural suturing, bone buttress, overlay fat, sealant, and then nasal packing. And for the grade 3, it's the full range of instruments. So we go for a multi-layer reconstruction with inlay fat, dural suturing, free graft, bone buttress, nasoseptal flap, fat over flap, sealant, and then the balloon. So here are some examples for the reconstruction. This is a grade 0 leak in a patient presenting with a microadenoma. As we see on the images here, the tumor is located in the inferior part of the cella, so the opening will be done accordingly. Upon opening, the tumor is resected and with aspiration and curette. This is a tumor cavity, so after showing cases, we just go for a Surgicel and then re-expanding the dural edges. This can be really enough for grade 0 cases, so like these microadenomas. Okay. Grade 1 cases where there is a small CSF whipping. So this is a large necrotic macroadenoma. After resection, we can see the cavity. There is here we can see a small CSF whipping, especially after Valsalva maneuver. The tumor cavity is quite large. Then careful inspection could also find a small defect in the posterior membrane of the cavity. So we go for a reconstruction. You can see here the river sign. We go for the reconstruction. So we thought to put one knot on that defect through a suture, and then here we check with the Valsalva maneuver. There is no CSF leak remaining, but still we complete our reconstruction with an inlay fat that is sutured or anchored to the dura in our running sutures. This allows for a better effect of the buttress bone. We add then the bone harvested from the septal cartilage, from the septal bone, sorry, and then we add some bioglue all over the construct. Another case of grade 1 CSF leak. This is a macroadenoma in a 42 years old patient. This was a macroprolactinoma actually. So during the extracapsular resection, we could notice some CSF weeping from the thin diaphragm, and also the arachnoid membrane here that is almost opened. So we complete the resection and then we expand the dura inlay fat that will be also sutured in this case to assure a maximum watertight closure. We add some fat and then put the bone buttress on place with some bioglue. This is a grade 2 case with obvious diaphragmatic defect and moderate leak. So here, during an early stage of the procedure, we've had CSF leak. You can see that bluish arachnoid membrane. So we didn't miss it actually. So we've had an early CSF leak at the early stage of the procedure. You can see here. And then a quite obvious diaphragmatic defect. So we continue on our tumoral dissection. At the end of the resection, you can see here the pituitary gland to the left. You can see that the CSF is continuing, is still leaking here. This is a tumor cavity showing hemostasis. This is diaphragmatic. This is diaphragm. So we put an inlay fat, a second inlay fat, and then suture the construct. Already at this stage of the reconstruction, we can see that there is no CSF leakage, but we still continue with the buttress. Here again, no CSF. But we add an overlay with fat and then bioglue. This is a case of a grade 3 large defect that happened as part of an extended approach for resection of a craniopharyngioma. So after resection, we put the inlay fat. We suture the fat to the dural edges. This assures some nice watertight closure. We'll see here, no CSF, but still we have the bulging of the brain pulsations. We add some onlay fat, the buttress, and then the overlay with the nasoseptal flap, fat again, and then fix it with the balloon. So, in conclusion, reconstruction should be kept in mind from the early stages of the surgery. Preoperative MRI workup is mandatory to try to identify anatomical risk factors for CSF leak, and also choose the appropriate approach. Is it be transeptal or paraseptal? To try to preserve your flaps, vascularization as much as possible in case you will need them, and then assure a maximum watertight closure. So that's it, I think. Yes, thank you.
Thank you very much for that nice talk and on an important topic. We'll save questions to the end due to our time restraints. Our next speaker is Dr. Bougrin from Morocco. We'll be speaking on ETV tips and tricks.
Thank you. So endoscopic third ventriculostomy is the gold standard for obstructive hydrocephalus, but however, we have some relative indications like repeated shunt malfunction or repeated shunt infections, post-meningitic hydrocephalus or post-hemorrhage hydrocephalus. The MRI is still important in the preoperative planning of these patients. The first ETVs were done in the early 20th century, and then they took advantage of technological advances. In the department, we are using rigid endoscope, 30-degree rigid endoscope, and to do the stomy, I prefer to use a forceps than a balloon. And I always use an arm in the procedures. The patient is in a supine position, and for children whose fontanelles are open, I prefer to use arciform incision to avoid CSF leaks. The surgical technique is well known. Everybody knows these videos of endoscopic third ventriculostomy. It is important to know the anatomical landmarks of the lateral ventricle, the third ventricle, and the floor of the third ventricle, where we will do the stomy in the thickest part. It is very important not to have wide movements, because no longer seeing the anatomical structures does not make them disappear. So you can hurt them. You can have fornix lesions or vascular lesions. When the floor is floating like this, it will be better to cauterize first and then do the third ventriculostomy. I used to open the forceps in the third ventricle before enlarging the hole to be parallel to the basilar artery and to avoid the injury of this artery. And it is very important to look through the stomy and to check the absence of Liljequist membrane to have a good surgery. And here is the basilar artery. So in ETV, what could go wrong? I would say almost everything, because we have a very narrow place to work on, and you have only one tool to use. So you have to anticipate the complications and to avoid them. The first is the bleeding. When it bleeds, we don't see anything. We are lost, and we have to, if you are in the third ventricle, you have to come back in the lateral ventricle. Rinsing is the thing to do. Here in this video, we will be able to follow the ependymoma until we find our anatomical landmarks and perform the stomy. But sometimes you have only to put an external drainage and to wait for a few days to reoperate the patient. We can also have abnormal anatomy, and the cases I will present were not the first, the ETV was not the first indication for them. It was always a secondary indication. Here is an abnormal anatomy. We don't see the foramen of Monro. In fact, there's no septum, and here we are in the left lateral ventricle. We are looking for our landmarks, and following the choroid plexus, we found the foramen of Monro. Here is the thalamic vein, and here is the septal vein, and the floor of the third ventricle, where we performed the third ventriculostomy. This is the video of 3 months baby with post-hemorrhage cyst in the occipital horn of lateral ventricle. First, we didn't see the foramen to do the ETV. We prefer beginning with the fenestration of the cyst. And then you see here, we can see the choroid plexus. Excuse me. The choroid plexus and the thickness of arachnoid. And we followed the choroid plexus from back to front. And then we found we were able to see the foramen of Monro. There's no septal vein, no thalamic vein, and the floor of the third ventricle. This is a video of a newborn, a 3 months also baby, operated at birth for encephalocele, occipital encephalocele, and then she has a shunt, and she infected her shunt, and we did the endoscopy. And here the anatomy is not normal at all. We searched our anatomical landmarks, the choroid plexus, the septal vein. We didn't be able to find it, and the floor of the third ventricle is here. In some cases, rare, we don't just we can just do anything. Endoscopically, I mean. 6 month baby, myelomeningocele and hydrocephalus, 2 malfunction shunts, and we tried to do ETV. Entering the lateral ventricle, we were able posteriorly to see the the catheter, the ventricular catheter, and we're looking for the third ventricle. Here is some choroid plexus. We thought it was here, but in fact this is the septum pellucidum, perforated septum pellucidum, and then we always follow the choroid plexus from back to front, and entering the third ventricle, you see this foramen of Monro is not normal, and entering the third ventricle, there is nothing we could do, so we freed the catheter, the ventricular catheter, from its adhesions, and it was the only thing we can see. And the last is just for showing. It's a baby with the multiple cerebral abscess, and we could multiple shunt malfunction. Unfortunately, we just could fenestrate all the cysts remaining after the abscess, and she's hopefully doing well. Here is her CT scan. In conclusion, ETV is a gold standard for obstructive hydrocephalus. A good knowledge of anatomy is very important, because not seeing anatomical structure does not mean that it doesn't exist. So you can hurt it by wide movements. We have to be gentle with our movements. The learning curve is steep, but as fast as we learn the technique, we learn our limits, and we have to anticipate the complications and the abnormalities of the anatomy. And I will just conclude with a call for abstracts for the Moroccan Journal of Neurosurgery. Here is the website, which is in your scientific program. Thank you for attention.
So now, thank you, Muna. Now call Dr. Darqawi to present his talk on reducing the risk of vasospasm in aneurysmal subarachnoid hemorrhage.
Thank you. It's my pleasure to be here. No. Okay. So, dear Chairman, dear colleagues, my talk is about a question. Can we predict and reduce the risk of vasospasm and delayed cerebral ischemia in subarachnoid hemorrhage? 24 centuries ago, Hippocrates described in his book Aphorism on Apoplexy, subarachnoid hemorrhage. He said, when persons in good health are suddenly seized with pain in the head and straightway are laid down specialists and breathe with stertor, they die in 7 days. Unless this date, subarachnoid hemorrhage remain feared disease with 2 feared complications, vasospasm and delayed cerebral ischemia. 50% of patients with develop or with the angiographic vasospasm will develop cerebral ischemia with a huge number of complications. And it is crucial to detect early signs of DCI to prevent its occurrence. So the question is how to predict the risk of DCI. We all know that high grade of WFNS and Sanders grade Fisher are related to high risk of complication of vasospasm of DCI. And what if we can add all these criteria, all these scores, all this data together in a scoring or grading system to define the group of patients with high risk of DCI. And this way we can expect to predict it earlier and help to reduce DCI occurrence, to engage treatment, aggressive treatment to minimize disease complication, and to treat ECU length of stay. And what we really need is not just to diagnose DCI, it's better to predict it, to avoid the complication of this DCI. And to predict it, many papers were published about this, and there is score stratification model to detect groups with high risk of vasospasm and DCI. Like this one, published in 2017, and hand-to-hand grade and the amount of blood in the cisterns on CT are the strongest predictor of DCI and clinical vasospasm. And even the area under curve here is better than those of ROG. It's another paper published in 2013 and presented 4 predictors. So it is possible to predict it. And in this other study, with the multivariate logistic regression model predicting DCI, there is 3 variables which are the most predictive factor: age, modified Fisher grade, and aneurysm location. And they give the authors give a value to every subgroup to define DCI, and as a result, there is the highest estimated risk with 38% of risk with 17 points, and lowest risk of DCI is found in patients older than 70 years old with modified Fisher grade 0 or 1 and posterior circulation aneurysm. Other authors added Doppler data, vascular dynamic data, to clinical data. And they can predict the occurrence of vasospasm with a sensitivity of 90% and specificity of 70%, and even predicts the occurrence of DCI, delayed cerebral ischemia, with a specificity of 98%. So it is possible to predict it and do what necessary to avoid complication. Do we need imaging? It's a good question, I think, because clinical support is not enough. Imaging CT scan is not enough because we will just diagnose the complication, the ischemia, the cerebral infarction. Doppler is not enough because we can study just middle artery, cerebral artery with correctly, and computed tomography perfusion, if we do it late, we just diagnose this. I think we can do early computed tomography perfusion to predict the development of DCI before its occurrence. So once we predict it, what we should do to prevent or to manage it if we diagnose it? Nimodipine, no doubt, it is recommended since during the last 4 decades, and with a high level of evidence-based medicine. But what about hyperdynamic therapy, where there is all of us use it, but there is no control study. And recent studies talk about the complication of induced hypertension for delayed cerebral ischemia, with serious adverse effects, what is comparable with other studies. And even the authors recommend to review and to reconsider recommendation about induced hypertension in subarachnoid hemorrhage. And it's obvious that every vascular neurosurgeon, once he clips the aneurysm, asks himself if he can do more than clipping. And in this paper, the answer is yes. He can do meticulous clot evacuation and fenestration of lamina terminalis and adversarial dissection of major vessel using papaverine. And by doing that, he can improve the incidence of delayed cerebral ischemia, especially in grade 4 of Fisher, with an improvement of vasospasm, but no impact on clinical outcome. It remains the same here. But if we add cisternal irrigation with thrombolytic agent, with plasminogen, nimodipine, or papaverine, the clinical outcome will be improved in addition to all these surgical tactics. So what about endovascular? Prophylactic balloon angioplasty is proposed, so we can improve vasospasm and cerebral ischemia, but not improve the clinical outcome, even in addition of papaverine during during intraluminar administration. Another paper used angioplasty and nimodipine in intra-arterial nimodipine, but in this new publication, 25% of patients who had arterial nimodipine and an additional angioplasty had cerebral infarction and persistent vasospasm in the half of patients, 10% of them because of complication of the technique of the endovascular procedure. And this risk is reported on different studies as well. So does it really worth the risk to continue doing that? I will conclude with this, with the guidelines of American Heart Association, American Stroke Association, published in 2012, and to say that I think it's time to include surgery in these guidelines, because by doing close evacuation, meticulous close evacuation, by doing cisternal irrigation, by doing what you call it, a good papaverine during cisternal irrigation, we can improve the outcome of this patient. Thank you.
Thank you very much for that nice talk. We'll go ahead and move on to our next speaker. It will be Dr. Bersali from Algeria. Will be speaking on clinical, radiological, and surgical considerations of craniopharyngioma surgery.
Dear colleagues, dear assistants, I will talk today about the clinical, radiological, and surgical considerations in craniopharyngioma surgery. In introduction, craniopharyngioma, despite their benign character, are malignant by their location in the deep brain, relationship with functional structures as hypothalamus, the relationship with functional structures as hypothalamus make the total resection very complex to perform, even by experienced surgeons. This is a lifetime disease, very challenging, and the difficulty remains on how radical should the surgeon be. The problematic in craniopharyngioma's management remains when it occurs in pediatric population. The choice of the optimal approach for a maximum removal, minimum of morbidity, and the best quality of survival. This is why the decision-making is based on clinical, radiological, surgical considerations, and every craniopharyngioma should have a specific treatment. Craniopharyngiomas can have a multi-directional extension in subtemporal spaces, in prechiasmatic systems, in subfrontal spaces, in the posterior fossa, in the cerebellopontine angle, in the skull-base system, and this is how. This is why we have clinical polymorphism, mainly the endocrine disturbances, the visual impairment, especially in adults, the hypothalamic disorders, the memory impairment, the mental disorders, and hydrocephalus. The radiological considerations are based on neuroimaging. We have to study the anatomical position of the craniopharyngioma, the nature of the tumor, if it is solid, cystic, or mixed, the relationships with surrounding structures, and the relationship with intracranial vessels, the presence of calcification, and hydrocephalus. The neuroimaging allows us to the determination of the relationship of craniopharyngioma with the pituitary stalk, the optic chiasm, the hypothalamus, the third ventricle, and the vascular structures. This is very important for classification in order to optimize the surgical approach for a maximum of removal and lowest morbidity. As we can see in this classification of steno in 2004, the position of craniopharyngioma toward the third ventricle allowed the surgeons to choose the surgical approach. As we can see, we have three types of craniopharyngioma: extraventricular, extra and intraventricular, and purely intraventricular. In this paper, Steno say that the two first types can be approached by transbasal approaches, and only the purely intraventricular craniopharyngioma can be approached by transcranial techniques. Now, the most important in craniopharyngioma surgery remains the hypothalamus. The relationship of the tumor with this functional structure can determine the quality of removal. If the hypothalamus is not involved, or if the craniopharyngioma only displays the hypothalamus, a gross total removal is possible. But when hypothalamus is involved, the surgeon must do only have not to be so aggressive. In our department, we use this classification based on the point of departure of craniopharyngioma. So we have the infradiaphragmatic type, we have the extraacromial type, we have two subtypes of intraacromial craniopharyngioma, and we have the intraventricular type. For the infradiaphragmatic on the extraacromial, we can only use the transfemoral approach, and the gross total removal is possible. For the intraventricular type, we have to use the transcranial approach, and the gross total removal is possible also. So now the problem is for the two other types, the intraacromial types. So the both approaches are possible, but often the hypothalamus is involved, so we can only do a subtotal removal. As we can see in the literature, we have many techniques to reach the craniopharyngioma dependent on its extension. But in this talk, I will only talk about the surgical approaches in endoscopic endonasal surgery, because this is the most procedure used in our department. So we have the indication of endoscopic endonasal surgery can reach 75% of craniopharyngiomas. This is a mini-invasive surgery. We use natural routes. We have no brain retraction. The pituitary style can be preserved. We have a low morbid mortality. The quality of removal is often satisfactory, and we have a better visual outcomes. The surgical technique, we have three steps of this approach. We have the nasal step, the sphenoidal step, and the cellular step. Now, for the surgical exposure, have to be large for a maximum of effectiveness. The limits are anteriorly the lumbus, posteriorly the clivus, and laterally the optic nerve recess and the internal carotid artery. When dissecting the tumor, we have to identify the hypophyseal arteries. We have the superior and middle ones, which are designated to the chiasm and infundibulum vascularization, have to be preserved. But the inferior ones, designated to the diaphragm and pituitary gland, can be saccharified. Also, the PCAM and perforating arteries in the retrochiasmatic space have to be gently dissected from the. Only the craniopharyngiomas rupturing the floor of the third ventricle can be removed by transbasal approach. The others are purely intraventricular, and only transcranial approaches can reach them. And the multilayer closure using the nasoseptal flap has allowed us to avoid the main complication of this approach, which is the CSF leakage. In conclusion, craniopharyngiomas management is challenging the most experienced neurosurgeons around the world. Every craniopharyngioma has a specific treatment which must be discussed by multidisciplinary group. All the clinical, radiological, and surgical considerations have to be discussed preoperatively to optimize the outcomes, and young neurosurgeons must be trained to perform all approaches to operate on craniopharyngiomas. And thank you for your attention.
Thank you for that very nice talk. We'll go ahead and move on to the next speaker due to time. The next speaker is not here, so we are finished. But if anybody would like to have any questions for any of our speakers, please go ahead. We have in the back.
Thank you for this good presentation. Ask Professor for we can use the blood silicone for repair blood silicone for repair the defect of sphenoid, the defect sphenoid, and the glue.
Silicone plate for repairing the skull base defect, right?
Yes.
Yes, sure. If you do have it. If you do have it. So otherwise we can harvest it from the septal or cartilage bone, yes.
Thank you very much. And Monsieur Darkawi, I asked him, is the good thing to use echodoppler intracranial for craniectomy before vasospasm, aneurysmal vasospasm, and large ischemia? You can use echodoppler intracranial in reanimation and units soins intensifs.
Well, thank you very much. I guess if we have no more questions, I want to thank the speakers for their eloquent talks, as well as the audience for their patience. Thank you very much. This will be the end of our session. Oh, you want to answer? Go ahead.
For echodoppler, yes, transcranial echodoppler, yes, it's very interesting to use it because you can use it one time per day or many times per day to follow this patient. And also, but if you have already an ischemia, it's not subject of my talk. But if you have already ischemia, the transcranial Doppler will help you to know if you are efficient or no with this patient with all treatment that you will install after this diagnosis. Okay?
Thank you very much.
So now we declare the session over.